My great honor and pleasure to have the opportunity to give a talk in this webinar, Vietnam. So today, I would like to talk about the diagnosis of HCC, mainly based on LIRAS and surveillance of HCC. I've heard that not everyone here is an abdominal radiologist. It might be a little less attractive because it's about HCC, but I did my best to prepare the content to be helpful to everyone. So let me start with LIRAS. Liver Imaging Reporting and Data System, LIRAS, is a comprehensive system that standardizes all aspects of HCC imaging, including terminology, technique, interpretation, and reporting. LIRAS is supported by the American College of Radiology and the American Association for the Study of Liver Disease, and is becoming the most widely accepted, sophisticated diagnostic system for HCC in North America. For diagnosis, the untreated lesion should be categorized. LIRAS can be applied in patients at risk for the development of HCC, including cirrhosis, chronic hepatitis B, and current or prior HCC. LILAS can be applied in currently, LILAS has 4 individual algorithms that are used in different clinical contexts. Ultrasound LILAS is used for the surveillance of at-risk patient. Contrast-enhanced ultrasound LILAS is used for the diagnosis of HCC. CT MRI LIRAS is used for the diagnosis and staging of HCC. Treatment response LIRAS is used following local regional treatment. Today, I will focus on CT MRI LIRAS. This figure shows categories of LIRAS. If observations cannot be categorized due to image degradation or omission, that is category error and C. The management in this category includes a repeat diagnostic imaging, usually within 3 months, with the option of using an alternative modality or contrast agent to improve diagnostic quality. If definite tumor in vein, RRTIV. If definitely benign, error 1, and probably benign, error 2. If observations are malignant but not specific for HCC, that's error M. According to CT MRI diagnostic table, observations can be categorized into error 3 to 5, reflecting the probability of HCC. So let's take a look at each category. Observations in error 1 have a 100% certainty of being benign. These are usually benign non-hepatocellular lesions or vascular pseudo lesions, including cysts, hemangiomas, focal fat deposition or sparing, and perfusion-related changes. As you can see, hepatic cyst and the typical hemangiomas showing peripheral nodular enhancement and the gradual enhancement are error 1. This is the case of a 48-year-old male patient with nodular focal fat deposition. On CT, there is a well-defined, ill-defined focal low attenuation nodule in S4. On MRI, you can see this lesion shows signal drop on outer face compared to in face, suggestive of fat, and this fat component is shown as high signal intensity on fat-only sequences. The nodule shows no arterial enhancement and low signal intensity on hepatobiliary phase, and also low signal intensity on fat-saturated T1 weighted image. Observations in LI2 have a high probability but lack 100% certainty of being benign. Recent reviews show that about 13% of observation in this category to be HCC and 13% of the observation to be malignant. The majority of LI2 are the same as LI1, distinctive nodule less than 2 cm without major feature of HCC LRM, and ancillary features favoring malignancy are categorized LR2. These include siderotic nodules, T1 hyperintense nodule, T2 hypointense nodules, nodules hyperintense on hepatobiliary phase. Siderotic nodules is a type of regenerative nodules having increased iron content. On this MR image of a 62-year-old woman with HBV liver cirrhosis, there are multiple small nodules showing marked dark signal intensity on T2 weighted image due to the T2 shortening effect of iron. And in phase, these nodules show signal drop compared to out of phase representing iron component. These nodules don't show arterial enhancement on arterial phase. As you can see, this CT MRI diagnostic table, LR3, 4, 5 are classified according to size, presence of non-rim arterial enhancement, and whether or not they show 3 additional major features. Additional major features are enhancing capsule, non-peripheral washout, threshold growth. The 30% of LR3 are malignant, with 38% being HCC. LR4 have high probability but not 100% certainty of being HCC. The probability of being HCC approaches 75 to 80%. LR5 have 100% certainty of being HCC. 95% of our LR5 are HCC and 97% are malignant. These are 2 cases of LR5 showing typical imaging finding of HCC in CT and MRI. On CT, the mass larger than 2 cm shows non-rim hyperenhancement on arterial phase and non-peripheral washout on portal phase. On delayed phase, you can see enhancing capsule. On this MRI, you can see a nodule larger than 2 cm shows non-rim arterial hyperenhancement and non-peripheral washout on portal phase. In addition, the mass shows also hypointensity on hepatobiliary phase and moderate high signal intensity on T2 weighted image and diffusion restriction on diffusion weighted image. How about this lesion? On CT, the nodule larger than 2 cm shows no arterial enhancement, but low attenuation on portal phase compared with the adjacent liver parenchyma, which shows non-peripheral washout. So according to the table, this nodule can be categorized as LI4. The ancillary features may be used for improved detection, increased confidence, or category adjustment. According to ancillary features, we can upgrade or downgrade category. If the lesion shows 1 more ancillary findings favoring malignancy, upgrade by 1 category. On the other hand, if the lesion shows 1 more ancillary findings favoring benignity, downgrade by 1 category. If the lesion shows both 1 more findings favoring malignancy and 1 more findings favoring benignity, do not change the category. It is important that ancillary features cannot be used to upgrade to LR5, which means we cannot upgrade LR4 to LR5 if there are ancillary features favoring malignancy. Ancillary features favoring malignancy is divided into favoring malignancy in general, not HCC in particular, and favoring HCC in particular. Features favoring malignancy in general includes US visibility as discrete nodule, subthreshold growth, restricted diffusion, mild to moderate hyperintensity on T2 weighted image, corona enhancement, fat or ion sparing in solid mass, transitional or hepatobiliary phase hypointensity. Favoring HCC features favoring HCC in particular includes non-enhancing capsule, nodule in nodule, mosaic architecture, blood product in mass, fat in mass more than adjacent liver. Ancillary features favoring benignity include stable size over 2 years, size reduction, perilous blood pool enhancement, undistorted vessels, iron in mass more than liver, marked T2 hyperintensity, hepatobiliary phase isointensity. Perilous blood pool enhancement can be typically found in hemangioma. As you can see here, the hemangioma shows peripheral enhancement similar to that of artery on arterial phase and portal vein on portal phase and IVC on delayed phase. This is the typical findings of hemangioma. Isointensity on hepatobiliary phase refers to signal intensity in hepatobiliary phase nearly identical to that of the background liver. Isointensity on hepatobiliary phase indicates the presence of functional hepatocyte typically seen in regenerative nodules, low-grade DN, and benign AP shunt, which you can see in this figure. And the wedge-shaped arterial hyperenhancement is located in the subcapsular area of the liver, and this lesion shows isosignal intensity on hepatobiliary phase. An MRI of a 43-year-old man with chronic hepatitis B, there is a well-defined nodule larger than 2 centimeters, showing non-rim arterial enhancement and non-peripheral washout on portal phase. The mass can be categorized as LI5. The MR scan also shows another small lesion in S8. This nodule is less than 2 centimeters, shows no arterial enhancement. However, washout on portal phase, so we can give LR3 to this nodule. However, this nodule shows hypointensity on hepatobiliary phase, which is ancillary features favor malignancy in general. Hence, we can upgrade the lesion into LR4. I would like to show you typical cases showing ancillary features favoring HCC in particular. So let me start with mosaic architecture. Mosaic architecture refers to the presence of randomly distributed internal nodules or compartments, usually with different imaging features. Internal compartments may differ because of presence of fat, fibrosis, blood, and vascular dynamics. On MRI of a 78-year-old man with HBV infection, there is a well-defined large mass in right hepatic lobe. The mass shows internal nodular structures, which shows different signal intensity on different phases. The multiple nodules or masses within a larger mass correspond to different foci of clonal expansion at different stages of hepatocarcinogenesis. Next, non-enhancing capsule refers to a capsule that is not visible as an enhancing capsule. So unlike this enhancing capsule, non-enhancing capsule does not appear as an enhancing rim. Nodule appearance represents foci of abnormal arterial enhancement within a liver lesion. It appears at MRI as arterial enhancing focus of HCC within this plastic nodule. This imaging feature corresponds to the characteristic histologic growth pattern of hepatocarcinogenesis, morphologic dedifferentiations, and clonal multiplication of less differentiated cells in the inner nodule, replacing the well-differentiated or dysplastic outer nodule. On pre-T1 weighted images, there is a nodule showing slight low signal intensity and a smaller foci showing lower signal intensity than outer nodule. And this small foci shows arterial enhancement and the diffusion restriction on diffusion weighted images. So we consider this to be a HCC within this plastic nodule. LRM category include targetoid mass and non-targetoid mass with infiltrative appearance, marked diffusion restriction, necrosis, or severe ischemia. Targetoid mass includes rim hyperenhancement, peripheral washout on portal phase, and delayed central enhancement, targetoid restriction on diffusion-weighted image, targetoid transitional or hepatobiliary phase appearance. Let me show you cases showing targetoid mass. On CT, the mass shows thick peripheral rim enhancement on arterial phase, and this doesn't show the washout on portal and delayed phase, rather shows the central enhancement on delayed phase. On this MRI, the mass shows peripheral washout on portal phase and targetoid appearance on hepatobiliary phase. So you can see the hypointensity rim in peripheral and with milder hypointensity in center. This mass shows rim arterial enhancement, peripheral diffusion restriction, and targeted appearance on hepatobiliary phase. And you can also see the capsular restriction, which is features favoring cholangiocarcinoma. Target-like morphology reflects peripheral hypercellularity and central stroma fibrosis or ischemia. Targetoid appearance is characteristic of intrahepatic cholangiocarcinoma, combined HCC and CCC, other non-HCC malignancies. However, it can be seen in HCC with atypical features. Therefore, targetoid appearance suggests non-HCC malignancy, but does not completely exclude HCC. So this algorithm provides imaging-based guidance for determining and reporting the most probable etiology among the more common causes. If LRM observation shows infiltrative appearance, probably represents HCC. If LRM observations shows features suggesting hepatocellular origin, it may represent HCC with atypical feature or combined HCC and CCC. If LRM observation shows targetoid appearance, it most likely represents intrahepatic CCC, combined HCC and CCC, or CCC with atypical features. So this is an interesting case of HCC with targetoid appearance. On CT, there is a well-defined low attenuation mass with relatively thick peripheral rim, and this rim shows arterial enhancement on arterial phase, but don't shows washout on portal phase. On pre-contrast image, the internal component shows high attenuation in dependent portion, so we thought that the mass has internal hemorrhage. Based on CT, we considered this lesion as cystic or necrotic mass with peripheral solid portion and internal hemorrhage. According to LILAS, this can be categorized as LRM. On MRI, this lesion also shows thick peripheral arterial enhancement, no washout, peripheral diffusion restriction. We can find another meaningful findings on MRI. I think this is the advantage from the MRI. On pre-T1 weighted images and T2 weighted images, the internal component shows high signal intensity on T1 weighted image and dark signal intensity on T2 weighted image, representing blood product in mass. And also we can see clearly the non-enhancing capsule on arterial and portal phase. So this lesion was confirmed as HCC after resection. I think ancillary features favoring HCC was helpful for diagnosis of this HCC with atypical features. So this is the last slide of diagnosis of HCC. Next, I'd like to move on surveillance of HCC. So let me start with the review of the current guidelines regarding HCC surveillance. The target population is high-risk patient for HCC with chronic viral hepatitis and liver cirrhosis. All the HCC guidelines across the world recommend US with or without alpha-fetoprotein every 6 months in these patients. The benefits of US as a surveillance tool are huge. Among the modalities for liver imaging, US is the least expensive and the most widely available. In addition, we don't need to worry about risk related to radiation or contrast agent. However, recent such studies have raised concerns about US sensitivity to detect HCC at early or very early stages. According to a previous meta-analysis including 15 studies, the sensitivity of US for detecting early HCC was 47%. Do you really think it's good enough? Although the number is roughly similar to the probability of flipping coins. To make it worse, the target lesion in the previous meta-analysis is early HCC according to the BCLC stage system. However, the target lesions for surveillance, particularly in a non-transplant setting, are in fact smaller ones, specifically smaller than 2 cm, as known as very early HCC. The size of the lesion is one of the most important predictors of clinical outcomes after local regional treatment. Physiologically, HCC smaller than 2 cm are known to have less aggressive and less invasive biologic behavior due to the absence of microvascular invasion and lower proliferative profiles. Thus, HCC smaller than 2 cm is the main target for HCC surveillance in a non-transplant setting in Asian countries, including Korea. So what is the diagnostic sensitivity for these lesions? There are 2 recent prospective studies from Korean which evaluate diagnostic performance of US to provide US sensitivity information regarding very early HCC. So let's take a look at the study outline of the previous study. The study prospectively enrolled 423 patients at high risk for HCC, specifically with annual HCC risk more than 5%. The diagnostic performance of complete protocol MRI using EOB was compared to US intra-individually. The sensitivity of US was very disappointing as it was less than 30%, while complete MRI showed 86% of sensitivity. This difference held true for stage 0 HCC, which is less than 2 cm. Also, the specificity of contrast-enhanced MRI was significantly better than ultrasonography. The second study design was almost identical to the previous study. 139 patients with annual risk of HCC more than 5% were included. Instead of MR in the previous study, this study compared biannual US and 2-phase low-dose CT intra-individually. Among 24 patients with HCC, 17 of them were very early HCC, which is less than 2 cm. The sensitivity was 29.2% for very early and early HCCs and only 70.7% for very early HCC, which was even worse than the result from the previous study. A study using explanted liver as a reference standard revealed that the sensitivity of US was affected by lesion size. Thus, when it comes to HCC smaller than 2 cm, the sensitivity of US is markedly decreased. In our daily clinical practice, we sometimes encounter patients with poor sonic window like this figure. Through the subcostal and intercostal approaches, the liver cannot be sufficiently evaluated as the liver is shrunken due to liver cirrhosis. The LILA suggested that on US visualization score system, it classifies the degree of visualization of the liver into the three categories. A means that limitations are unlikely to meaningfully affect sensitivity. In the score C, limitation significantly lowers sensitivity for focal lesion detection. So, can you guess how frequently we encounter insufficient US scored as C? From the previous study data, almost 30% of US scans were regarded as score C. So it's quite mind-boggling, isn't it? So in these patients, is it okay to stick to US as a surveillance tool, even though it looks like aiming targets without seeing it? And also this study evaluates changes in image quality of US during the follow-up round. As you can see here, the majority of patients with inadequate quality of US on initial US persistently show inadequate image quality on follow-up scans. So let's get back to HCC guidelines. The previous version of HCC guidelines from Europe, the United States, and Korean described US as the sole imaging modality for HCC surveillance. However, recent evidences regarding the limited performance of US in HCC surveillance culminates some interesting changes in the major HCC guidelines, which were revised in 2018. All the three major guidelines from Europe, the United States, and Korea allow the use of an alternative surveillance tool, such as CT or MRI, in selected patients with a high likelihood of having an inadequate US. In the era of CT, the diagnostic criteria for HCC are super simple. If the nodule bigger than 1 centimeter shows arterial hyperenhancement and washout during the portal or delayed phase in patients having risk factors for HCC, we can make a diagnosis of HCC without any other invasive method. However, in the area of MRI containing multiparametric information, it's not that simple. So let's take a look at the important milestones of HCC guidelines. I know that this slide looks very busy. However, it reflects ceaseless changes in the guidelines. Since the EASL proposed the first guidelines in 2001, over the past 2 decades, lots of organizations and societies from Korea, Japan, Asia, the United States, and Europe have published imaging-based criteria for HCC. 2018 is the year of great changes in terms of the guidelines of HCC, since the main three guidelines from Korea, the United States, and Europe have been revised this year. One of the most prominent changes in the revision of all these guidelines is the active adoption of EOB MRI as a first-line imaging modality. The superb diagnostic performance of EOB MRI have been proven by the recent meta-analysis. It's one of the major changes in AASLD and EASL in 2018, while the Korean guidelines have embraced EOB MRI as a major imaging modality since the previous version. However, in terms of the interpretation of imaging features in EOB MRI, there are some differences. Why do all different imaging systems exist? It can be explained by the fact that each system should address different target populations, medical resources, and treatment practice. Korea is one of the highest HCC prevalent countries. MRI is available at affordable cost due to the National Health Insurance System. The mainstay of treatment for HCC in Korea is hepatic resection or RF ablation rather than deceased donor transplantation in Western countries. Thus, sensitive diagnosis for HCC is more important than specific diagnosis, which is quite different from the Western world. Hence, the imaging method and diagnostic system for HCC vary according to different geographic area. So let's take a close look at specific differences in diagnosis criteria for HCC across the guidelines. Here's the case of a 65-year-old man with hepatitis B-related liver cirrhosis. We can see a nodule in hepatic segment 5, measuring as 1.1 centimeter in diameter. On T2 weighted image and on diffusion weighted image, the lesion has mild to moderate high signal intensity. And we can find the presence of the fat in the lesion. On dynamic studies, the lesion shows arterial hyperenhancement. We cannot see any washout on portal and the transitional phase. However, we can see hypointensity on hepatobiliary phase. So do you think we can make a definite diagnosis of HCC in this patient? In fact, depending on the criteria, the answers are different. So let's start with the easy criteria, which propose the simplest diagnostic approach. According to these guidelines, only arterial and portal venous phase can be considered when you make a diagnosis HCC on EOB MRI. The radiologic hallmark on EOB MRI are defined as arterial hyperenhancement and washout only in the portal venous phase. So we cannot diagnose this lesion as HCC. So I suppose it's somewhat ridiculous not to consider information from the other sequences. In fact, what's the point in performing EOB MRI if we are not allowed to utilize the full information? Let's move on to the AASLD guidelines. The AASLD guidelines also define the washout in EOB MRI only in the portal venous phase. Transitional or hepatobiliary phase hypointensity is merely regarded as ancillary features favoring malignancy. So as this nodule does not fulfill the major features, we cannot call it as a definite HCC. However, this nodule is considered as probable HCC due to the presence of the ancillary imaging features. So how things are going to change in the Korean guidelines? The different from the previous two guidelines, the Korean guidelines generously extend washout to transitional and hepatobiliary phase. Thus, this nodule can be diagnosed as a definite HCC as it has the major imaging features on EOB MRI. In fact, the lesion was pathologically confirmed as HCC. As we've seen in the previous slides, the timing of determining washout appearance in EOB MRI is one of the major differences among the guidelines. The reason why the Western guidelines stick to confine the timing only during portal venous phase is the fear for losing the specificity in the diagnosis of the HCC. The DC studies published in 2015 warned that the specificity would be decreased to less than 50% if we encompassed hypointensity during the transitional or hepatobiliary phase as washout. However, if we take a closer look on the data, we can see the majority of false positive cases were hemangiomas and cholangiocarcinomas, which can be easily excluded based on ancillary imaging features. All of you must be familiar with gadocetic acid, which is a widely used MR contrast agent for liver imaging, as it has a unique property as a hepatocyte-specific MR contrast agent. With a lipophilic modification of gadolinium DTPA, this contrast is taken up by hepatocyte through an anion transporter called as OATP1B3. Thus, EOB can give tissue-specific information, and uptake of background liver can offer high CNR on hepatobiliary phase. Recently, two studies from Korea and France performed a head-to-head comparison between conventional extracellular and hepatobiliary contrast agent. In both studies, the sensitivities on EOB MRI were markedly improved when the washout appearance was extended to transitional or hepatobiliary phase, which were better than ECCM. The proportions of the washout appearance were increased in the timing of the washout appearance were extended, which explains the improvement in sensitivities in EOB MRI. Regarding specificity, as you might expect, the specificity of extended washout on EOB MRI was significantly lower in comparison to ECCM in the French study. However, the specificity of extended washout remained 100% even with extended washout in the Korean study. I believe that the use of exclusion criteria can be attributed as a factor to explain such differences between the two studies. The Korean study has clarified that they used exclusion criteria before applying diagnostic criteria. Contrarily, the French study has not mentioned whether the authors considered exclusion criteria or not. As we saw in the previous slide, extended washout appearance beyond portal venous phase on EOB MRI had different specificity according to the adoption of exclusion criteria. The Korean study taking ancillary imaging features such as marked T2 hyperintensity, which is a finding of hemangioma, or a targeted appearance in tone count, showed higher specificity than the French study, which did not consider them. Washout timing affects significantly the sensitivity of HCC diagnosis on EOB MRI. In my humble opinion, strict confinement of washout timing to the portal venous phase on EOB MRI, as endorsed by the Western criteria, is not legitimate given that the purpose of EOB MRI is enhanced sensitivity. I suppose hepatobiliary phase hypointensity should be considered as a major feature when EOB used as a contrast agent. Exclusion criteria for common false positives are required to maintain specificity. So here is a summary of the differences of major guidelines of HCC. The Korean guidelines differ in the Western guidelines when it comes to the timing of washout. The EASL guidelines do not specify the use of exclusion criteria, while the other two clearly declared exclusion criteria. So this is the last slide of my talk. The imaging plays a critical role in diagnosis of HCC because diagnosis is usually made non-invasively in appropriate at-risk patient. LIRAS is a comprehensive system which provides a standardized means of assessing and communicating the spectrum of lesions. For appropriate diagnosis and management of HCC, we need to know features characterizing HCC. The imaging method and diagnostic system for HCC vary according to different geographic area. When EOB is used, diagnostic criteria should be focused on boosting sensitivity with acceptable loss of specificity. Thank you for your attention.
Thank you very much, Wesley, and with the interesting your presentation about the different category of the LIDAR and the role of the CT scanner in MRI. and with the different villi you review from the Western and USA and also in Korea. And I think that's in Korea, in Vietnam, it's similar for the population and HCC. So some characteristic similar between the Vietnamese and Korea. I think that's very useful for us and in routine. Thưa các quý đại biểu, chúng ta đã vừa nghe cái báo cáo rất hay của Australia về cái phân loại LIRAD trong cái tổn thương của gan trên các cái hình ảnh cắt lớp vi tính cũng như là cổng từ và cái vai trò giá trị của cắt lớp vi tính so với các cái phương tiện khác hơn rất nhiều so với siêu âm. Và chúng ta đã được nghe cái phần review về các cái hướng dẫn trong các cái mốc quan trọng, trong các cái thay đổi trong các cái năm vừa qua, trong các cái hướng dẫn chẩn đoán. Thì với những các cái quy trình khác nhau của châu Âu cũng như là của Mỹ và đặc biệt là của Hàn Quốc thì chúng ta thấy là một số các cái mô hình bệnh tật, đặc biệt là ở Việt Nam thì cũng rất là tương tự so với lại ở Hàn Quốc đối với những bệnh lý về ung thư gan. Thì đây là một cái báo cáo rất là hay và ta có một cách nhìn tổng quan trong các cái chẩn đoán. Thì xin mời quý vị đại biểu chúng ta có đặt câu hỏi. Quan thư ký có tập hợp được câu hỏi nào cho các trường hợp quý đại biểu cho Australia không?
Dạ, hiện giờ là chưa có câu hỏi cho phó giáo sư Ly ạ. Chắc là mình sẽ đẩy phần câu hỏi này đến cuối buổi ạ.
Yes, up to now. So I have a question for Professor Lee. So in Korea now, how about do you use EOB MRI in contrast agent for all case when you suspect of HCC or it depends observation?
In our institution, we use nearly 100% for the liver MRI with the EOB, and some institution use the extracellular agent for several issues, such as arterial enhancement issues. So, as you know, the Primobist has a problem with the arterial enhancement because the patient had respiratory difficulties during the arterial phase after injection of contrast. So due to those kind of problems, some institutions use both ECCM and hepatocyte agent, but maybe I think over the 90% of institutions in Korea use Primobist for the liver MRI, especially for the diagnosis or management of HCC.
Yes, so EOP contrast agent is very useful for HCC, and I think that's there's some area, for example, in Vietnam, as you know, because the number of patients, a lot of patients for MRI, and the second is the contrast agent is very expensive.
Yeah.
So that's the problem for the insurance, something like that. But for the sensitive and specific for the EOP is very good. Yeah. And I have another question. You recommend on the study about the lower dose CT scanner. So
for the diagnosis of HCC?
Yeah, low dose. That's a low dose non-contrast, and after that for contrast, you use the standard dose.
Until now, I do not recommend the use of low dose CT for HCC diagnosis, but as you know, the dim learning reconstruction for the low dose CT has developed, and I think that's very helpful for the improvement of image quality, especially the GE. So so I think if we can confirm the image quality with help of other techniques such as deep learning reconstruction or spectral images. So yeah, I can use the low dose CT for the HCC diagnosis, but until now, and my institution cannot use those kind of deep learning reconstruction for the low dose CT until now. So I do not use the low dose CT. Yeah.
Yeah. And last question, what do you think about the dual energy CT scanner or HCC?
Do you mean the vendor?
Dual energy CT scanner? Dual energy.
Energy? Oh,
Yeah.
energy. We usually the 100 kV. Is it? Am I?
Yep.
Did I have a right answer?
What your energy CT scanner?
Pardon? Can you rephrase the question one more?
Yes, your energy means that's the different kilovolt. For example, 120 kilovolt
Yes,
and 80
100.
kilovolt, right?
Yeah, for the liver 100.
Thì có câu hỏi tôi đã có trao đổi với giáo sư Ly về một số các cái điểm. Thứ nhất là chỗ Hàn Quốc hiện nay thì họ dùng cái thuốc tương phản ngoại bào, gần như là hầu hết các cái trường hợp nghi ngờ chẩn đoán cái HCC ung thư biểu mô tế gan, thì cái này chúng ta thấy là có rất nhiều các cái ưu điểm trong các cái chẩn đoán. Tuy nhiên thì như chúng ta biết là cái thuốc tương phản ngoại bào hiện nay ấy, thì như Việt Nam chúng ta đang có những thuốc ví dụ như là Vimovis thì nó cũng khá là đắt tiền. Và thứ hai là cái thời gian chụp, thấy là các cái delay nó kia, chúng ta có cái khoảng thời gian thì nó sẽ cái số lượng bệnh nhân chúng ta nhiều và cái giá thành nó đắt, cho nên là cái này nó cũng chưa được phổ biến nhiều. Tuy nhiên nó rất là có giá trị, và nay chúng ta đang áp dụng ở khá của một số các cái đơn vị trung tâm. Thế thì cái này là cái chúng ta cũng cần quan tâm trong cái việc chẩn đoán, và đặc biệt nó rất là nhạy giá trị. Thì cái thứ hai nữa là cái trong cái bài báo cáo thì giáo sư Ly có đề cập đến các đơn vị tính điều thấp. Thì tôi cũng có hỏi, thì hiện nay ở chỗ mặc dù là có cái báo cáo về các cái giá trị của các đơn vị tính điều thấp, nhưng mà chỗ trung tâm của sư Ly thì cũng không sử dụng nhiều cái này. Còn các đơn vị 2 mức năng lượng thì có sử dụng rất là thường xuyên. Ban thư ký có nhận được câu hỏi thêm gì chưa?
Dạ, hiện giờ là vẫn chưa có thêm câu hỏi từ các bác sĩ ạ.
Okay, and now Professor Lee, can you stay with us at the end, and so we continue with the next presentation?
Okay.
Tiếp theo chương trình thì xin mời báo cáo của hãng G về ứng dụng các cái phần mềm trong chẩn đoán bệnh lý về ung thư gan. Xin mời.